Hello, hello, and good evening, good afternoon, good morning, everyone. Welcome to another continuing education webinar hosted by ourselves and SWOC, and we're in partnership today with Ergo Medical Canada. So we really thank them for being able to make today's education possible. Before I introduce the session and our guest speakers today, I want to just go through a couple housekeeping items. First things first, my name is Troy, and I'm the Chief Operating Officer of Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm tuning in from Ottawa, Ontario, and I would like you to click on that chat button in your Zoom toolbar and let us know where you're tuning in from, maybe what your job title is, or maybe where you work across Canada. If you're international or abroad, feel free to let us know where you're tuning in from as well, too. It's always great to see our colleagues from across the world even joining in on some of these webinars. So welcome everybody. We're going to be recording today's session. So if you have to leave early or if you have a colleague you know who isn't able to attend live but might want to watch this back later, you're welcome to do so. We'll have the recording available on our nswoc.ca website alongside all of our other past webinars. It usually takes us about a day or two to get it up there, but we will make sure to do it as soon as we can. We're also going to be doing a Q&A period at the end of this webinar. So as you have questions throughout the presentation, please use the Q&A button in your Zoom toolbar. So not the chat, but that Q&A button, and that'll make it super easy for us to be able to get to as many as possible at the end of the presentation. Everyone online today will also be receiving a certificate of attendance. So same thing with that recording, just give us about a day or two and we'll get that into your inboxes as well. So without further ado, I'm really excited to introduce our guest speakers for today's presentation on Vashe, now in gel form, which is really, really exciting. So firstly, we have with us today Josée Sénéchal, who is a nurse specialized in wound ostomy and continence with a surgical background and strong passion for wound and ostomy management. She completed her master's degree in community health and wound prevention and care in 2020 and has been providing education to healthcare facilities across Northern Ontario. Josée is also a faculty member at the Wound Ostomy and Continence Institute, where she serves as an academic advisor for the ostomy portion of the tri-specialty. And she currently works as the project management specialist for lower limb preservation at the Mawonsing Ontario Health Team, where she focuses on prevention and management of complex lower limb wounds and supports multidisciplinary collaboration to improve patient outcomes. And we're also joined today by Korina Owen, who is a clinical nurse specialist in wound care at Mount Sinai Hospital in Toronto. She also holds a master in clinical science and wound healing from Western University and is certified as a nurse specialized in wound ostomy and continence. She's also a certified foot care nurse. And at Mount Sinai, Korina provides hospital-wide consultation for complex wounds and specializes in advanced therapies, including amniotic membrane application. She's also presented at Wounds Canada Conference and is currently preparing her first co-authored research papers for publication, which is also very exciting. So what I'll do, I forgot to put your photos on screen there, but I'm sure you'll recognize them by their cameras a little bit later. There's Korina and Josée. And I'll just put the disclosures on the screen for everyone to be able to take a quick second to review and look over before we get into today's presentation. While you're doing that, just another quick thing is we're going to be doing a couple polls here. So as we get throughout the presentation, you might see a little question pop up on your screen. If you're on your computer, you can just answer it there. If you're on your phone or tablet, you might just need to swipe over to the side to respond, but we'll leave that open and I'll mention that once we get to the polls later on. So without further ado, I'll pass it over to you, Josée. Thanks for being with us today.
Hello, everyone. Thank you so much for having me. All right, so let's start this off with a bang. So let's talk about today's wounds are more complex than ever, right? So my biggest challenge in my clinical practice are often just chronic wounds, right? So it's meeting that client that's had these wounds for many, many years. They've tried every product, but ultimately they have no improvements or they're just not closing. But why is that, right? This is what we want to know. So as we know, chronic wounds, up to 100% of chronic wounds contain biofilm. Pardon. Biofilm regenerates within 24 hours, so this is why sometimes it's so challenging. Wounds require serial debridement. I'm from Northern Ontario, so I live in Sudbury, so sometimes we don't have the skills or abilities in the communities or in other areas to actually do that debridement for us. We also know that chronic wounds have an alkaline or their more pH is higher, which impedes wound healing. And this was a pretty big stat when I saw this, is that Canada sees over 260,000 antimicrobial resistant infections annually. So I think that's pretty huge. All right, next slide, please. Sorry about that. So, in 2025, the International Wound Infection Institute came out with their guidelines for therapeutic skin and wound cleansing, and they came out with this diagram to really depict how optimum wound care needs to kind of take form to kind of be able to treat our complex wounds. So you'll see here we need three different things. We need our therapeutic wound cleansers, we need to implement debridement, and also wound dressings. We'll go to the next slide, please. So when we're talking about this international document, within this document, they also stated that the hypochlorous acid is ultimately the best wound cleanser. So they're looking at this is the most recommended wound cleanser. And not only is it recommended in that document, but also in the last few. So since 2018, we have a lot of new documents that have been coming out. So best practice guidelines, recommendations, and even updates are changing their recommendations to using pure hypochlorous acid as their wound cleanser for all of our wounds. So we'll go to the next slide, please. So when we're looking at optimal wound care, remember that first step was therapeutic wound cleansing. So as we know, we were talking about hypochlorous acid today, but I think most of us know it as Vashe, right? That great cleanser that's in that dark blue bottle. So again, this is where I'm going to be talking a little bit more about Vashe and how this works. So we'll go to the next slide. So pure hypochlorous acid is used by the human body as a natural response to invading pathogens. So what does this really mean, right? So hypochlorous acid is produced by the human body by neutralizing invading pathogens. So after a pathogen enters the body, neutrophils are quickly deployed from the bloodstream to kind of respond. So this is called oxidative burst. Can't say this one, burst. And this is kind of what it looks like, right? So pathogens are targeted and engulfed by the white blood cells. Hypochlorous acid is generated within the white blood cell. And then again, pathogens are destroyed by the hypochlorous acid in this action. So as you can see, the residual material is removed through exocytosis. So we'll go to the next slide. All right, so hypochlorous acid is proven effective against fungi, spores, viruses, and multi-drug resistant bacteria. So VASH wound solution utilizes our pure hypochlorous acid. And again, like I was saying, it mimics the body's natural oxidative burst that we were talking about. So this is again where those white blood cells or the neutrophils generate that hypochlorous acid to kill those pathogens. So this provides a non-cytotoxic, a pH neutral antiseptic that effectively disrupts that biofilm and kills 99.999% of bacteria within 15 seconds. So again, this facilitates faster healing of our chronic wounds. So right now I keep talking. Oh, I'll go back one more second. Yeah. So right now I keep talking about this oxidative burst, right? So let's talk about that a little more. So oxidation disrupts the protein structures of the amino acids, which ultimately means we're weakening the slough and microbes and the biofilm. So the mode of action of VASH on slough is that oxidative debridement. So oxidative debridement is the newest term. It's been around for a while, but I feel like I'm hearing more and more about it, especially when I'm reading it through various consensus documents. But ultimately, it supports debridement of slough and can be used in complement, ultimately, with sharp debridement, mechanical, or even autolytic debridement. Next slide this time. Perfect. So we know that hypochlorous acid is safe from head to toe and safe from key cells. So as you can see, hypochlorous acid has been identified as a non-cytotoxic solution. So this is when we're talking about wound bed prep, this is where we're usually looking for those non-cytotoxic cleansers, right? And before this, I believe it was only normal saline that was non-cytotoxic. So what this means is that this is really safe. And this is safe around mucous membranes, so our mouth, our nose, our eyes, those areas. It's non-irritating to the peri-wound skin. It has no known contraindications. And again, it's even safe for peri-care in those types of areas. Next slide. Great, thank you. So let's talk about the pH of hypochlorous acid, right? And how does this affect wound healing? So I think everybody knows hypochlorous acid. It's the big one. It helps with pH. And I always like to start this slide with talking about how healthy, intact skin how it has the pH of between 4 and 6. And I think the great thing about that is because it's in more an acidic environment, hypochlorous acid, who has a pH of 3.5 to 5.5 is mimics just the skin. It's very, very similar. So as you can see, hyperchlorous acid helps with antimicrobial properties. It's favorable for wound healing. And again, it preserves a lot of those skin functions. You'll also see on this diagram here how you'll see there's other different types of cleansers that we've seen before, right? So like sodium hypochlorite, those things also often have toxic ingredients. You'll also notice that they're in that higher range. So they're more in that alkaline. They have a pH higher than 7.5. So what that usually means is, unfortunately, it allows pathogens to thrive. So a lot of our microbiomes and all of those are just getting worse. They're just thriving in there, getting larger. It impedes healing. It actually promotes inflammation, irritation, as we know is a big one for our chronic wounds. And another thing that I find is kind of a fun fact is it actually has the same pH as our chronic wounds. So a lot of our cleansers aren't really helping as much as we think they are. So we'll go to the next slide, please. So now when we're looking at hypochlorous acid, like I just think this product is great because ultimately it's checking off all of the main boxes, right? So in terms of safety, we know it's non-cytotoxic, which is great. It has that micro, I can't say this one, antimicrobial efficacy. So ultimately, as we know, it's effective against a wide variety of microbes. It has that debridement effect. So we were talking about that oxidative burst. It has the same pH as the human skin. So again, this is still healthy and safe for our skin. And we've also seen from earlier on that it's part of many, many consensus documents, including best practice guidelines. So again, we know that this is a safe product that has been backed by a lot of different research. So when we're looking at here, I think this is where we always have, oh, so I'm just going to say that hypochlorous acid, again, it's so great because you can, not only is it safe, but there's also other ways that we can be using it. It doesn't have to be a standalone product. We could be using it with other debridement methods. Another good one is negative pressure wound therapy with installation. So I know that this is a great one that I like to implement into my practice. We'll go to the next slide. All right, so back to that diagram of optimal wound care. So now we're going to talk about our wound dressings, right? So once we've done our therapeutic wound cleansing, we know that we have a great wound bed. Now let's try to put something back on top of that wound. So I have a few questions for you guys, and we'll see what the group agrees on in terms of what they're using for topical wound care dressings. We'll go to the first question. All right, so Troy will be popping up a poll up. So the first question is, how often do you use wound gels or topical creams in your practice? Feel free to vote. I think you can vote, oh, single choice, just once. Mm. Oh, sorry, wrong one.
I realize I'm doing the wrong one. That's my
Yeah,
fault.
we're
Here,
doing them
let's end
backwards.
that poll. We'll come back to that one. Let's do
We'll
this
come to
other one
that one.
here. Sorry about. Let's do this. How often do we use wound gels or here we go.
Cream.
Let's
Yes,
try
let's
this
do
one more
that
time
one.
there. Sorry about that, everybody.
So how often are we using wound gels or topical creams in your practice? Daily, several times a week, once a week, occasionally, rarely, or never. Let's see what the group says.
So we're about 50% participated now, so we'll end that and you can see the responses in front of your screen now.
All right, so we have a little bit, everybody's kind of giving me a different answer here, but I think the majority says several times a week. So that's pretty high. And then the second one would be occasionally. And then the third highest is actually daily. Okay, that's great. Karina, how often are you using gels and topical creams?
I would say occasionally. And I think as we were kind of preparing this presentation, we talked a little bit about some of the gels or topical gels and creams that we use. I'm sure everyone's familiar with, medical grade honey, the hydrogels that are available. And then the other ones that we talked about too was metronidazole and flamazine and Santal, the enzymatic debridement gels as well. So those would be some of the ones that I see in my practice, but definitely occasionally. I really very particular types of wounds, not very, very often. What about you?
You're right. I'd also say occasionally, as you're right, it's not for everyone. It's not for every wound. And I find sometimes it's challenging because this may be a new product for some, so they don't actually know how to use it, right? It has a kind of sometimes a little technique that you have to use. So yeah, you're right. I agree. Let's try the next question. All right. Next question is, let's hope it's this one. We'll see if it pops
Yeah,
up.
let me get this one going here. I was just gonna
I was
quickly
reading
switch
this.
it to make sure it's a multiple choice now. Try
Perfect.
this
There
one
you
out,
go. This
everybody.
one you can answer. You can click on a few. So the
Or
question is,
several, yeah.
which type of wound gels or topical agents okay, so what types of wound gels or topical agents are currently part of your practice? So we have hydrogels, gels or creams with silver, enzymatic debridement gels, honey-based gels, silver type creams, topical antibiotics, other or I don't routinely use gels.
We'll leave that open for a second, and I'm pulling back the curtain a little bit, but I'm just gonna fix that other question I previously launched to make sure it's multiple choice here in the background. So keep on selecting while I get that done for everybody.
Oh, good. And while we wait, Karina, what about you? What type of gels are you usually using?
I think I listed some of them for the last question. I forgot we had this one right after that.
Oh,
But I would
good.
say probably the one that I use the most would be the hydrogel. I like to put that over bone, especially like cartilage, bone, tendon, anything that I really want to keep moist, especially if I'm trying to kind of decrease the dressing frequency. I think we talked about too, like the honey. Really, the only time I ever use that is like an oral cancer wound, just because it's, safe to ingest. So that's about it. I actually don't not familiar with the silver gels or creams, so that's a new one for me. What about you?
Ready? I'm, oops.
Do we have an answer from the group yet?
We should here. Let me end it, and you should see the response in front of you right now.
Look at that.
Oh, great. So it looks like a lot of people are using a lot of this, like a little bit of everything. So this is awesome. But it looks like the highest percentage is hydrogels. So, and I would agree. Do you know what? I probably use a lot of hydrogels in my practice where I want to really try to soften up that dry black eschar. We also have, what's the second highest? 41% topical antibiotics. Yep, yep. And then we also have honey-based. So yeah, we're a little bit everywhere. So from 67 to 20, 30, 40%. So yeah, looks like we're using lots of topical gels and topical agents. This is great. Okay, let's go to the next.
Alrighty. I'm gonna try to, we're gonna relaunch it here. We'll see if this works. If it's, I don't know if I was able to get
Mm,
the checkbox options, so I apologize, everybody. If you have multiple, maybe what your primary goals are. If you have multiple primary goals, maybe just put that in the chat there. If it's not one of the ones on the screen, or if you need to put an additional one in.
Perfect. So the question is, when you select a wound gel, what is your primary goal? It says choose one, but we all know we might be using them more than once. So the options are moisture donation, supportive debridement, antimicrobial efficacy, biofilm control, healing promotion, burn management, or odor reduction. Fine for me when I have these wounds. I wish I could have more than one, right? I find sometimes certain products, you're only using it for moisture donation, or you're only using it for burns, or you're only using it for biofilm, right? So, ooh, I'm wondering what everybody uses. What's their number one choice?
Alrighty, we're about 50% participated here, so I'll end this and I'll share it in front of you so you can see what's coming up there. And I know in the chat, some people are responding some other options too.
Perfect. Okay, so it looks like moisture donation and support of debridement is actually pretty much almost neck and neck, 33 and 31%. So yeah, I'm using my gels for those reasons too. Okay, what about you, Karina? Are you using them for anything else?
Yeah, I
Healing
agree.
promotion was pretty
Definitely
high.
yeah,
Yeah,
debridement and moisture donation, like I
moisture.
said,
Yeah.
keeping underlying structures moist and viable, and then, like you said, softening really
Yeah.
tough, thick.
Perfect. Okay. Well, great job, everyone. Thank you so much for participating. Those were great. So, I was wondering, let's move to the next slide then. I kind of talked a little bit about that. Yeah, perfect. And we click one more time there, Troy. Perfect. So, like I was kind of hinting earlier, it would be nice if we had a product out there that would help with wound healing, antimicrobial properties, also support debridement while providing, again, moisture or even just managing moisture. So, it'd be nice if we had some sort of product that would do that for us.
And here it is.
Yay!
This is Vashe Wound Gel with all the benefits of hypochlorous acid, but now as a primary wound care product. Next slide, please. So, Vashe Gel, like we talked about, addresses multiple needs within a complex wound environment, such as eliminating biofilm, supporting debridement, donating moisture, reducing odor, and promoting wound healing. Just like Vashe Solution, Vashe Gel has a pH that is conducive to wound healing with no known contraindications or clinical resistance. Next slide, please. And similar to the solution, Vashe gel can be used on a variety of wound types, including our stage 1 to 4 pressure ulcers, partial and full thickness wounds, graft and donor sites, exit sites, intact skin, diabetic foot ulcers, venous leg ulcers, arterial ulcers, post-surgical wounds, first and second degree burns, dermatitis, and surgically or mechanically debrided wounds. Next slide, please. So one of my favorite things about Vashe gel is really how easy it is to use. And this slide lays out really nicely the steps for applying it. So we still recommend cleansing the wound before application. This can be done with Vashe solution. We want to be extending not just cleansing our wound bed, but all the way into the peri wound. We can also do a compress or a soak with Vashe soak, the solution soaked gauze, and we want to leave that on about 5 to 10 minutes. You want to remove that compress if you've done it that way, and then thoroughly wipe the wound bed and peri wound. And then you can move into applying your Vashe gel. So for a superficial wound, first things first, for any wound, you're going to want to shake the tube very well. You want to make sure everything is nice and combined, nothing has settled in the bottom of the tube. And then when applying directly to the wound bed, you want to be applying it in about a 5 millimeter thick layer. So it's about the thickness of a nickel. And then you can go ahead and apply cover dressing of your choice, and then go ahead with daily dressing changes or dressing changes based on your clinical judgment. We'll go to the next slide and I'll go into a little bit more detail. So like we said, we talked about applying directly to the wound bed. Here's a nice little example of that thickness, that nickel thickness. And then the alternative, the other way to apply it is for packing. So when we talk about packing our wounds, we know we want to make sure that, you know, the entire dead space, the all of the area of the wound is packed with some sort of material, right? We say fluff, don't stuff. So what we can do with Vashe gel, which is really awesome, is you can either apply it directly to the wound bed and then fill that remaining space with, for example, Vashe solution, soaked gauze, or ribbon. Or what I like to do, and what I've done a lot, as you'll see in my cases, which we're going to talk about, is I actually saturate that plain packing material directly with the gel. I use either, you know, plain ribbon or even sterile gauze, and then put like a heavy coat of the gel. I would say really better to be a bit more generous, and make sure that all parts, all surfaces of that packing material that are going to be in contact with the wound have the gel on it. And then you can go ahead and fill that space as you normally would. This works really, really well for narrow tunnels where it's hard to apply gel to the base, or even for wounds where there's kind of you're worried about the gel, you know, sliding or slipping, or especially once that exudate starts to pick up, if you're using it for debridement, it's a really great alternative to kind of hold things in place. And I want to go a little bit into more detail about the cover dressing. So when we say choose an appropriate cover dressing, it may be kind of self-explanatory, but you're obviously picking a cover dressing that is corresponding with your level of exudate. So how much drainage you have, you're going to want a dressing that's going to accommodate that level of drainage. When we think about what Vashe gel does with the debridement, you're also might expect that you're going to have that oxidative process happening. You're going to be liquefying a lot more of that necrotic tissue, leading to an expected increase in drainage. So you want to kind of think ahead. And if you know there's a lot of necrotic dead tissue slough in that wound bed, it's that drainage is going to ramp up, especially in the first couple of applications. So you might even want to opt for a super absorbent dressing. You also want to think about how occlusive that dressing is, right? The more occlusive a dressing is, the more risk of maceration at the wound edges, especially, again, if you're going to have a lot of exudate. So two things to consider when thinking about the cover dressing. The next thing I want to touch a little bit on is that dressing change frequency. For me, I like to look at this as considering the purpose for which I'm using the gel, right? Like we just talked about. If we're using it primarily to debride, we know there's going to be more drainage. So I typically, in that case, change my dressings daily. I also like to just make sure I'm cleaning out all that dead liquefied tissue, that bacteria. I want to get rid of that and then reapply a fresh coat of gel after I've cleaned the wound really well. Versus if you're using the gel on a relatively clean wound and you're just, donating moisture or, using it for its antimicrobial properties, you probably could get away with changing it less often, right? Maybe every other day or twice a week, whatever makes sense based on your clinical judgment and wound bed characteristics. So these 4 steps are really my formula, and I use these steps for all of my cases, which we will get into in the next slide, I believe. And we could skip ahead to the next one. Thank you. So this first case study, I have aptly named Stubborn Graft and Donor Site, and stubborn it was. Next slide, please. So this was a 68-year-old gentleman with a very persistent donor and graft site. He had a history of controlled type 2 diabetes, A1C of 5.8%, and he had underwent a scalp resection of squamous cell carcinoma in December of 2024. He had a left thigh donor site and a scalp graft site, which never closed. And you can see here, I received the consult to see him in June of 2025. So already 6 months, this wound's been open by the time I start to see him. He did have wound cultures that showed heavy growth of staph. And really, between the time I started seeing him and when we started using the Vashe gel, which was another 6 months, as you'll see in our photo timeline, we had tried everything. And I mean, really everything. We had tried every antimicrobial impregnated mesh, iodine, silver. We had tried even just petroleum. We had been using Vashe solution for some time as our cleanser. We used maltodextrin powder and gel. We tried him on the methylene blue gentian violet foam, cadexamer iodine powder and gel or ointment. We had really exhausted all of our options in terms of wound care products. And the tricky thing with this gentleman, and one thing I'll say, having my background being in the acute care setting, but also having a chance to work both inpatient and outpatient, is this gentleman lived in Northern Ontario. He was driving about 2 to 3 hours to see me, and he could really only do that about once a month. So not very frequent follow-ups, as I typically get to do with my inpatient population, and really relying on him to acquire his own supplies. It was very challenging to set up home care, especially since he was so far out of being in the post-operative phase. So he was buying a lot of his products himself, and then also needing to change the dressings himself. Him and his wife were doing that at home. So a lot of challenges to consider when looking for a product that was feasible for him at home, but was also going to help with wound healing. So let's move to the next slide. And you'll see this is what it looked like. So really, I will say deceptively clean wounds in appearance. This was in December of last year. So like I said, again, another 6 months that I had been seeing him. So now we're looking at a year from his initial surgery. And the scalp wounds there, you can see they look fairly clean, and so does the leg. But what would happen is he would come to me with these super thick scabs on his scalp. And when you would press, you would see how fluctuant they were, and there would be purulent drainage that would be escaping underneath of the scab. So we'd have to debride those away every time, and then you would just see this very mucky wound bed. It was very painful for him. He had had radiation on the scalp as well, so that was another factor that was impairing the healing. And then the leg as well, you can see just how fragile that tissue was. You can see the blood on the underpad. Very sensitive wound, very difficult to remove the dressing. He was in a lot of pain. And we'd had no change from previous visits. I'd been seeing him monthly, and really we were stuck at this phase here. So what did we do? We cleansed everything with Vashe solution, which we had been doing for some time. I applied a nickel-sized thick layer of the Vashe gel to all the open areas, and then we covered it with abdominal pads, and I think the leg we secured with cling, and we had him do that daily. What was really great about, again, the ease of use of Vashe gel was that he could do this completely independently. It was very easy for him, and the gel completely absorbs. So there was no need to remove residual product. So the pain was much decreased when he was changing his dressings. And that's always a bonus, right? If we can have dressing changes that are not super painful for our patients, it's a welcomed. Next slide, please. So here you go. You can see we did it for about a month. So every day he was doing this at home for a month. He came back to see me. And you can see all of the areas that were open are now closed, which was really amazing progress for us. And he had a few little scabs, but nothing like what he was coming in with before. There was no fluctuance. There was no purulent drainage underneath them. Just really a spectacular turn of events for this gentleman. Next slide, please. And here is the leg. This photo really gets me so excited. He was actually the first patient I used Vashe gel on, period. So I had very low expectations. Given everything we had been through, really, I was not expecting the wound to have changed really in any way, but definitely not to this extent. You can see not just the size, obviously, that's changed, but the tissue quality. There was no bleeding. It was like that peri-wound skin was pretty much back to his normal coloring. Wasn't so red and angry and inflamed. Like just incredible results. So he was thrilled. I was thrilled. And it was, again, very easy for him to do. So really, really happy with this. And it got me wanting to use it on other wounds. We will get into my next case here. So this one here, we can go to the next slide. Thank you. So this was a 70-year-old gentleman who had undergone a complex nasolabial reconstruction. I'll get into a little bit more of these kind of surgical terms here. He was a lifelong smoker and was actively smoking even after surgery. So that was an added challenge to his case. So he underwent a resection of a cutaneous angiosarcoma, a very rare and aggressive type of cancer. It was actually in the inner corner of his eye, just next to the nose. And unfortunately, because of how aggressive it was, he did require an orbital excineration, which is a very big word that basically means they removed everything. They took the globe of the eye, the eyelids, the deeper muscles, the nerves, the fatty tissue, a lot of cartilage and some of the orbital bone as well. A massive surgery and required a free flap reconstruction as well. So they took a deep fatty flap from elsewhere on his body, filled that defect. A very complicated surgery, very challenging to heal. Again, also had undergone radiation. It's a very common theme for my patients. And unfortunately, the distal corner of that flap, right by the tip of his nose, kind of extending down, you'll see in the photos, it'll make a little more sense, became ischemic and required debridement. And the surgeon had decided at that point best to leave it open to heal by secondary intention. There was really no ability to fill that space with another local flap. And part of that ischemia was likely contributed from his smoking, unfortunately, and the radiation. Next slide, please. So here it is. This was probably one of the most challenging wounds that I've dealt with, just in terms of location. It's kind of hard to see in the photo, but the wound bed was so dry. Like I had never seen it was like a big crusted scab of slough and debris. And even the granulation tissue that was there completely dried out. Again, he's breathing out of that nostril. There's a lot of airflow there constantly. You can actually see the exposed nasal mucosa, and then also a little bit of cartilage as well. It was very sensitive at the distal edge of the wound. The flap had no sensation, but really impossible to debride. It was just so sensitive close to his nose. And in order to get this to fill with new tissue, we had to get rid of what was dead there and not serving us anymore. So difficult to debride, difficult to dress. His nose was always running. He needed to clear his sinus. It was very challenging. And we were really concerned that the cartilage would dry out and require further excision. So definitely wanting to keep that moist and wanting to get rid of some of this non-viable tissue. So this is an example of where I didn't feel like I wanted to apply the gel directly to the wound bed. I was worried it would slide around, and I knew I was kind of going to have to stuff something in that area anyway. So like I said in our application slides, I saturated just a little ball of 2x2 gauze with the gel, pushed it into the area and secured it with a steri strip, or sometimes we actually used a larger kind of band-aid. So a very simple dressing, despite what the wound looked like. And we also had him and his wife change it daily. He was also from further up north as well. He was driving about 2 hours to see me. Again, another frequent theme for me in our clinic. Next slide, please. And this is him a month later. So you could see in that day 8 slide there, it might be hard to see actually with the coloring on the slide, but there was a new granulation bud on the cartilage, which was super encouraging because really that was the only way we were going to get this to fill in, as if we could get new granulation tissue to cover the wound completely, and ideally the cartilage as well. All of that slough and debris was soft, and you could actually see the epithelial migration at the distal edge. You could literally see the edge advancing, and particularly in that day 31 photo, it was really, I was pretty shocked at how much the wound had decreased in size and the way in which it was starting to shrink down. It was, again, a very tricky wound. I'm still seeing him, and it's improving. That cartilage bud continues to grow. I'm really hopeful that it's going to just migrate over the rest of the wound. So a really incredible turnout for this gentleman. Next slide, please. So this case study, we're moving away now from the outpatient surgical wounds, but nonetheless to a wound that is just as challenging. I'm sure most people here are familiar with the diabetic foot ulcer, notoriously hard to heal wound, and this patient really was no different. Next slide, please. So this was a 65-year-old gentleman who actually came into our emergency department at the end of February. So very recently, this was one of my more recent cases. He had a new diagnosis of type 2 diabetes that was actually found when he was admitted. He had come in for a foot that was, red, painful, had evolved into a blister on the top of the foot, and wasn't improving. So when he came in, we found out that it was in fact related to his type 2 diabetes. Of course, having not known that he had diabetes, was very much uncontrolled. His A1C was about 12. And he was also a lifelong smoker and drove 5 to 6 hours a day for work, which would prove an additional challenge for his case. Next slide, please. And this is what it looked like. So again, like Josée was saying, that boggy fluctuant eschar, that black tissue that we just want to get rid of. And this is where Vashe gel comes in really, really handy, which you'll see in the next couple of slides. But he did have a small open area, which was about 2 centimeters deep, quite extensive, considering what the wound itself looked like. He, on the plus side, he did have good sensation in his feet, and he did have normal blood flow, normal waveforms, good pedal pulses, which was a blessing for sure. On the flip side, he also had osteomyelitis in his 3rd and 4th digits. So a very unfortunate situation, something that just evolved incredibly quickly. And now we were going to deal with it. But I'll get to the next slide and you'll see something very fun that I discovered. So on the bottoms of his feet, I found a very thick callus, which he personally told me had been there for many, many years. Immediate red flag for any wound care clinician that deals with diabetic feet. So, of course, being the foot care nurse as well at my hospital, debrided this callus, and sure enough, you might have to skip ahead a little bit. Oh, yes. So there we go. That was what was underneath. And it was actually a very malodorous pocket of purulent drainage. And you can see with my Q-tip there, it actually probed right through to the wound on his dorsal foot. So a very, very, very extensive diabetic foot ulcer. Next slide, please. So what did we do? Well, we did what we've done for the last two patients. We cleansed really well with our Vashe solution. We applied the 4x4 gauze, which was saturated with the gel, over that eschar. And then we packed the open areas with about a 1/2 inch ribbon saturated with Vashe gel. So it kind of combined my two application methods that we talked about. Covered it with abdominal pads and again, changed daily. Next slide, please. It's about to get very graphic. So yeah, you can see how well that Vashe gel really worked. I did actually see him in between day 1 and 3. I was seeing him every day at this point, just with how um, complex this wound I knew was going to be. And it just absolutely liquefied everything. So again, really important to consider your cover dressing. Thankfully, the folded abdominal pad was enough, and you can see his edges actually look quite good despite the residual eschar there. But yeah, liquefied everything. And there was exposed tendon in the bottom. You can really see the oxidative debridement at work in that photo. And that continued. We kept up with the daily dressings. The exposed tendon remained, but you could see a lot more of that kind of sluffy necrotic tissue just coming away with every visit. So I didn't have time to put in an updated photo for him, but we've continued to use it, and there's more granulation buds now in the wound bed, which is very encouraging. And actually, the plantar wound no longer communicates with the dorsal wound. It's still quite deep, but it no longer goes straight through. Next slide, please. And here's that bottom wound. So we did the, again, same thing, Vashe gel packing, and you can see how much the size of the wound had shrunk, and then also the depth as well, right? It's no longer communicating. Still, obviously, a very significant deep tunnel. But that's what I like about the gel. Like you can soak your packing material with it and really get it right to the base, especially when it's hard to see, like it was in this gentleman's case. And we also did get him a custom offloading shoe. So we're doing a bit of everything for him. Next slide, please. And my fourth case here, I think this is my second last one. Back to our surgical wounds. So this was another outpatient that I had seen with a surgical incision this time. Next slide. So this was a 55-year-old lady with a dehisced surgical wound on her lateral lower leg. So she is interesting. She had actually underwent a right mandibulectomy. So they take a piece of your mandible out due to squamous cell carcinoma in her case. And then in order to reconstruct the jawbone, they actually take a piece of your fibula and they put that bone in place of where the jawbone had to be resected. So she had this left fibula wound due to that removing the bone from that area. She didn't have any other relevant medical history, which was great. She was undergoing radiation for her neck and mandible, but really not having too much of an effect on the wound healing in the leg, which was good. And so next slide, you will see this post-operative dehiscence. She actually came in again with very thick scabs running all along the incision, which we sharp debrided and revealed all of these kind of mixed granulation, sloughy open areas. There was a few areas where there was subcutaneous tissue exposed, but otherwise relatively clean. So for her, again, cleaned with Vashe solution, went all the way around into that peri wound, applied our nickel-sized thick layer of Vashe gel to all the open areas, covered with an abdominal pad, secured with cling, had her change it daily. Again, super easy for her. She was thrilled to just be able to, almost like, lotioning your legs, just rub this gel on, make sure she had a nice thick layer on there, and then cover it up and go about her day. Next slide, please. And I think we can just reveal all of our images if you thank you. So you can see by day 4, she came back to see me, which was great. And I got a nice look at really the full extent of the wound. So you can actually see at the proximal part of the incision that exposed tendon. So a lot more extensive of a wound than we had previously thought. And typically wounds where tendon is exposed, very challenging to close. But you can see by day 16, it was like there had never been any tendon there in the first place. She pretty much had epithelial islands forming between all of those open areas. And by day 32, pretty much the entire wound was closed aside from that small area at the proximal aspect. She did have radiation dermatitis actually in the peri wound. You can kind of see it there. I think I drew arrows pointing to some of those spots. She had it all on her hands and her neck as well. So unrelated to this initial surgical wound and not related to the Vashe gel. This was a separate issue, which some good moisturizer will do the trick for her. And that was her. Next slide, please. So finally, my last case here, and honestly, one of my favorites actually, a surgical wound with a very deep dehiscence. Next slide, please. So this was a 28-year-old young guy, which is not very common actually in our clinic at all. And he had underwent a melanoma resection in January. So he had that resected from the back of his neck. He had it closed with what we call bilateral rotational flaps. You can see in the photo an example of that. So they really, in order to limit the tension on the incision, kind of pull tissue rotated from different directions to close the space. The incision, again, because of that process, extended from his left neck, so completely around the side, and then down across his right scapula. So it was a very extensive incision. And he had actually come in for suture removal and was not on my consult list, didn't have plans to see him. But thankfully, one of our clinic nurses who was removing the sutures noticed a small area of dehiscence. And I actually wrote a note here. He did have an initial dehiscence when he was right out of surgery in the post anesthesia care unit, and they actually just further reinforced it with sutures. So already that wound was coming apart. He was on biologics, so immunosuppressant therapy. He was in university, very active, and so he had actually declined negative pressure wound therapy postoperatively because he really didn't want it to be in the way of his program. He was in clinical placement. He didn't want to draw attention to his condition. He was really just trying to power through his program. So that was not an option for him. Next slide. So here it was, once all those sutures were taken out. This is post-op day 15, and you can see that visible dehiscence. And there was actually about 1 centimeter of depth, and it undermined all the way around for almost like 2.5 to 3 centimeters. You can see just from how jagged those edges look, how much tension was on the incision, which was likely the cause for the dehiscence in the first place. And then also just that dead space underneath. There was really nothing holding that tissue together anymore. It might be hard to see in the photo, but there was really heavy bacterial burden with large volumes of slough. There was really no granulation tissue visible at all. And there was a lot of redness in the wound edges. So did the same thing, cleansed with Vashe solution, packed the area with 1/2-inch plain ribbon saturated with the Vashe gel, covered with a folded abdominal pad, and changed it daily. He was not able to do this himself, so I did set him up for some home care in a community clinic, but he actually ended up having his girlfriend do it, which was not my ideal preference for a wound like this, but again, just kind of speaks to how easy the Vashe gel really is to use. Next slide, please. So this guy called me about 2 days later, I think, and said he felt a pop when he was putting his socks on, came in and saw how much more this had dehisced. It was expected, really, for me. I wasn't surprised to see this, given how much dead space was under there. Wound was now 6 by 6, and again, about 1 centimeter deep. But there was some granulation buds in there, and the redness at the edges was much improved. He did have a lot of exudate, so we actually upgraded him to a super absorbent. And we just continued with the same orders. Next slide. And voila, you can see really just that ongoing granulation tissue formation. There's, again, oxidative debridement happening, all of that fluffy tissue. Even actually in that incision at the scapula, by day 19 was pretty much closed at that point. Really a tremendous outcome for him given how extensive this wound was. And it was actually down now to about 5 centimeters by 5 centimeters. So a full centimeter in each direction of decreased size. So really great stuff for him. And that is it for my cases.
Oh my gosh, good job, Karina. I'm giving you a high five. We'll go to the next slide, actually. I don't have my cases. I don't have that many cases. I have one. We'll go to the next slide. So today we're going to be meeting a 35 to 45-year-old man. He has chronic venous stasis wounds to his bilateral legs. He's had various wounds for about the last 18 months. Some of them in particular, he was like, I've had for a long time. So a lot of these wounds, he said, have just been opening and closing over the years. He has a limited medical history. He wasn't really open to sharing too much. He does have a history of substance misuse, so he does use various street drugs. He is unhoused. He does do that couch surfing scenario, and he's been mostly caring for his wounds independently. He does go to the emergency department or walk-in clinics when his wounds do get too bad, and then he gets the supplies, does the best he can, and then once he runs out, he kind of just takes care of himself. So we'll go to the next slide, please. All right, so this is his left leg. So this when I met this individual, we were already doing Vashe soaks for about 5 to 10 minutes prior to all dressing changes, and they were then putting Bactiguar over top, covering it with an ABD pad and Hypofix. So as you can see, there's quite a bit of maceration around the wound edges, but they also have that large kind of caked on wound edges of that slough and just drainage all over. So ultimately, and you can also see some mild erythema. So um, at this point, I was kind of like, I want to use the Vashe gel to try to soften up those edges, which you kind of can't see in some of these other wounds. But then I was worried about that maceration, like that wetness. I was worried that, this is just gonna bring more wetness to this wound and oh, this might be a disaster. So we'll go to the next wound. So I used Vashe gel anyways. So what I did is that I just put a thin layer over top. You can go to the next one, don't worry. So you'll see in the first photo. So what I did is that I put a thin layer, or not thin, the appropriate amount of Vashe gel over top. Because I was worried about, again, how much it would stick, I actually put a non-adherent over top, put an ABD pad and Hypofix. But because I was quite worried about that maceration, I went back 4 days later. And as you can see, the maceration wasn't there. This was amazing. You can actually kind of see a bit of that friable tissue was still kind of present, but ultimately it's looking a lot better. And then on day 15, so this is actually a couple days ago, you can see that most of these wounds are 100% almost healed. I would assume that give them another week and these would be totally closed. But ultimately, you can notice there's a few small scabs noted in that hypopigmented area, but that's just a lot of scarring from, again, multiple years of just these wounds opening and closing, opening and closing. I will go to the next slide. So that's his left leg, a little bit more of a closer view here. You can't really tell, but those edges were thick. That dry slough at the wound base that was totally covered, that is thick, thick, thick. Honestly, you couldn't do anything to them. So as you can see, after day 4 and day 15, these wounds are healing. They're not friable anymore. This is big time. These are changing the way I'm seeing a lot of my venous wounds right now. So we'll go to the next slide. So this is his right leg. So kind of the same idea. As you can see, he has wounds in, again, different healing needs, right? He has some wounds that are quite wet, but then he also has some really dry ones. And it was great that I was able to use the exact same product on both. So again, thick layer of Vashe gel, and then, well, let me back this up. I do a Vashe soak because I do love them for about 5 to 10 minutes. Then I would give it a good scrub in there, and then I put the Vashe gel with a non-adherent and then ABD and Hypofix. And as you can see, these wounds are just healing. We'll go to the next one just because I want to be cautious of time here. So as you can see, day 1, that really thick, kind of sluffy base. By day 4, pretty much almost gone. And day 15, they're non-existent. These have closed 100%. So this is huge. So this is an individual that continues to have wounds at all times. We can go to the next slide. I think I have one more photo. Yeah, so this is his right leg. So as you can see, this is an individual that always has wounds. These ones in particular, he did say that he's had open for over 18 months. So these wounds specifically, he's like he thinks this is like magic. This is the greatest stuff. So the good thing is that this is something that even the unhoused can do because he even said he's like, I can do this. I have a bunch of buddies that would be able to help with this as well, right? So the idea is that you just got to cleanse the wounds really well and then put the Vash gel and just any cover dressing can really make a really big difference. So I think that this is a kind of a game changer for a lot of clients that I see. We'll go to the next slide. So as you can see, this is great. We found a gel that can do a lot of these things for us. It promotes, supports debridement, moisture management, promotes healing, antimicrobial properties, and honestly, this product is amazing. So I've really enjoyed it. We'll go to the next slide super duper quick. Um, Yay. And you'll also see maybe this is Troy's slide, but if you're going to the NSWAT conference in Vancouver, Ergo Medical will have a booth and they'll also have Vash gels, and I'm sure they'll be giving out samples out. So if you guys are going, make sure you make a pit stop.
Amazing. Well, I'm glad that Ergo wanted to put this in there. That matches my background here too. So we love to see that. And Ergo will be doing a presentation as well to kick off our Congress in Vancouver. So we hope to see you all there. On that same note, I know we've got a lot of questions in the chat here about how can I get a sample? How can I test this out? I see Kathleen from Ergo was just mentioning that they have to be make sure that they're compliant with your health authority. So if you do want to look into that, please get in touch with your Ergo account manager in your area. What we'll maybe do is when we're replying back with your certificate of attendance in your email, if you want to maybe reply back to that, we'll give you some directions there. Maybe that's a good way we can help keep those all organized for you. Anyways, I know that we have Debashish Chakravarti, who's one of the VPs with Ergo Medical Canada as well on the line in the background. If you want to come on, feel free. We've got lots of questions. I know we're running just a little bit over time, but we're going to be able to get to as many as we can here, I'm sure. So I'll invite Debashish to come on.
Hey, good afternoon. Can you hear me?
Yes, absolutely.
Okay, there's a lot of questions, and how much time do you have for me to answer
Well,
them?
tell you what, maybe we can go through as many as you're comfortable doing here with the team. Maybe for another 10 minutes or so, 5 to 10 minutes. For those who have to head out early, just a reminder, we are recording today's session. So if you want to watch back the Q&A portion because you have to leave, it will be available online after. But as many as you can get through, Debauches, maybe over the next 5, 10 minutes.
Okay, all right. So, I can let me tell you, put it in context why this gel was created. This gel was created to force multiply the Vash wound liquid cleanser. And we have data that I hope to show at the meeting in Vancouver that truly, if we have biofilms involved, you give it a gut punch with Vash solution when you soak it for 5 to 10 minutes. But you give it a triple gut punch to the biofilm if you then follow it up with a Vash gel application. Now, you will notice that the gel is runnier than some of the thicker, goopier hydrogel dressings that you may have been used to. They have a lot of garbage polymers in them. I like call them garbage polymer because they don't bring anything to the wound other than residues and maybe some property of moist wound healing. Vash gel, in comparison, is a very, very simple product. It has a mineral thickener, and its viscosity is just so. Any lower than that, it would be very runny. Any thicker than that, it would not work. The hypochlorous acid just would not behave the way you want it to behave, which is providing antimicrobial preservative properties in the wound as opposed to silver containing dressings that are on the wound, in versus on. Big difference. Now, it is designed to be changed as often as you can change it. If you can change it daily, try to change it daily. If you cannot, because it's under a compression wrap, then you change it at every dressing change. But I had some questions on whether they can do away with the solution if you're using the gel. And I would say no, I do not recommend that based on the synergistical data that we have. There's a ton of questions on compatibility with various products. I think there is some confusion, and I'll take the blame for that because medical communication can be confusing, particularly when there are two products which have common roots but are different. It is Vash solution, the liquid, that you should not pour into a silver dressing to soak the silver dressing and then apply it on the wound. If you do that, you will not get the benefit of the hypochlorous acid liquid. In order to use the Vash solution, you soak it. 3 to 5 minutes is what we say. Some people say that say 5 to 10, because if you say 5 to 10, then people will do it for 2 to 5. Listen, anything more than a transient spray type application is good. And soak it for a little while as long as you can afford it. I think the law of diminishing return kicks in around 5 minutes time. You don't get any additional benefit after that. I'm talking about the solution. The gel will last in the wound depending on a number of factors: the amount of germs you have, the amount of exudate that you have, the amount of necrotic tissue that you have, the depth of the necrotic tissue. These are very difficult to model in a lab setting to measure how long it'll last. But when we have tried it on any given model, it lasts longer than the solution. But it's not meant to last over one day or over 2 days, that I can tell you. So changing daily is good. Changing twice a week, 3 times a week is good enough in our opinion, and work continues in this area. Now, in terms of compatibility of Vash gel with other dressings, the only product that I'll ask you to be careful of, and this is based on my friends who are in the gentian violet wound dressing business. I've heard that Vash gel will that turn that dressing white in color, so clearly some interaction happens. I would not use the gentian violet dressing directly on the Vash gel, although it is fine to use it after Vash solution use. If you pat it dry, you can use any dressing, including gentian violet dressing on the wound that has been treated with Vash liquid. For the gel, people in fact use ergocrine AG quite effectively. And there's a poster that will be presented in a wound care meeting in the USA soon, where people have used it together. Now, we did not start telling people that use it together, but both are debriding products and people use them together and they show really excellent results. So again, I will repeat, if you have soaked your wound with Vash solution, after you pat it dry, you can use any dressing, no exceptions. We recommend after soaking with the Vash solution for 2 to 5 minutes, you can apply the Vash gel, and then you can apply any dressing of your choice. A silicone bordered foam dressing seems to be particularly popular choice. Um, the only exception is on top of the Vash gel, you should not probably apply the gentian violet dressing. Change it once a day is good. If you can get close to it, that's good. If you're putting it under a compression wrap and you apply a gel and change it after 7 days, I won't be critical of that practice, but probably you want to get it in at least once more during the week. I think that answers a lot of the questions I asked. Let me see. Let me go over it. Um, is there any RCT done? Oxidative debridement versus other forms of debridement? Not yet. This is something that we will be thinking of doing down the road. Is it safe to use over a bone? Yes, we are allowed to be using it on stage 4 pressure ulcers, for example, that have bone exposure. And so there should be no issues. How does it help improve maceration? Listen, it's an empirical observation that maceration is reduced with the use of Vash gel. I don't have a very good answer to that question. Use of Adaptic with the gel is fine. As I told you, there's no problem. What about use with matrix type dressings? Yes, no problems there. One of the big users of Vash antimicrobial wound gel is the use on grafted wounds. If you have applied graft on a wound and you're concerned about germs destroying the graft, apply the Vash gel liberally. It's also really good for donor sites, and we have a presentation on that. Um, a question, if you don't have Vash gel, can I substitute with wet, moist, and Vash solution until I get the gel? Absolutely, you can do that. Um, Chlorhexidine compatibility. We say do not mix it with chlorhexidine in the liquid form. So don't mix Vash liquid with chlorhexidine liquid or other liquid cleansers, thinking two liquids mixed together are good. We do not recommend that. Use one or the other. I do recommend you use the Vash solution, obviously. Um, I think, let me see, it can be used with dissolvable sutures. It's early days yet. I don't have data on this at this point, but we will keep an eye on that. We don't have any indication one way or another. Are there any products Vash gel is contraindicated with? There's no contraindication as such, but I think gentian violet dressings turn white, people have told me. So probably you don't want to use those together. Um, Question about a surfactant containing gel. I will not name brand names. Is that a lower pH than us, or is Vash gel lower pH than them? I do not know. I do know Vash gel is at a pH of between, I think it is around 4 to about 6 in that range. So pure hypochlorous acid. Why would you opt to use packing with Vash gel versus Vash soaked ribbon? Again, early days, people are finding good results with soaking with Vash antimicrobial wound gel and soaking a ribbon and putting it in a tunnel. I think you may get a better degree of debridement that way. Treated osteomyelitis? No, we don't have any record of osteomyelitis treatment. I doubt whether antibiotics is what you want to be using, and use of the gel on osteomyelitic bone is fine, no problems there. Um, I think I have answered
I
all the
think that was
questions.
fantastic. I know I gave you a bit of a timeline, and I'm impressed by how many you were able to answer there. I'm sure this won't be the last questions we'll get about the Vosh gel, but as we've mentioned throughout the presentation here, there's lots of great resources if you get in touch with your Ergo account manager. As I said, we are going to be sending both the link to the recording today as well as your certificate attendance over the next day or two as soon as we can get them completed, and you'll be able to get in touch with Ergo that way. But I want to say thank you so much to Dr. Chakravarty for answering the questions, to Korina and Josée for
Hey, I
really
just
amazing
have
cases. Yeah, please go ahead.
one just quick comment on peri-wound. Its use is really good because it leaves no residue. And I want to end by one unique use that has come to our attention. I told you about the graft use. One big study that we are going to be presenting is to control lymphodematous oozing bacterial
Mm.
proliferation on lymphedema legs. Even without a wound, you have oozy stuff coming out. Bacteria love it. And slathering it on and putting a compression dressing really works because it leaves nothing behind. And this is another unique property of this gel, or it leaves very little behind. Sorry to interrupt, and I'll shut up now.
Not a problem. And I know we had Kathleen was in the chat mentioning how to get in touch with Ergo. Kathleen, I've just allowed you to speak if you wanted to say a few words about getting in touch about Vosh Gel.
Yeah, of course. Thank you so much for all of the interest. As mentioned, we just want to make sure we're going to follow the health authorities in the contract. So if you do not know who your Ergo account manager is, please email me at kathleen.reich@ca.ergo.com and please inform me of where you are located. That way, I'll make sure to connect with your Ergo account manager, and then we'll be able to follow the policies and protocol of your province. So thank you so much.
Thanks, Kathleen. And I'll put your email maybe in that follow-up email that we send out so then it's easy for anyone who might not have been able to write it down. So we'll get that for you too. So without
Thank
further
you
ado, I'll
so
say
much.
thank you to Josée again. Thank you to Korina. Fantastic presentation. Such cool cases, such great images as well. So I hope you both have a good rest of the evening. And for those on the call, we look forward to hopefully seeing you in just around 6 weeks in Vancouver for a joint congress. And if we don't see you then, we hope to see you at another webinar in the near future. Have a great night, everyone.